Redo coronary artery bypass grafts. Recurrent problems with coronary artery disease and reoperation is becoming uh, common and is indicated in the symptomatic patients who have coronary artery bypass grafts in the past, if they are symptomatic and have multiple coronary artery disease. So the indications could be anatomic, like atherosclerotic stenosis in the vein graft that supply particular territory, multiple stenotic vein grafts that supply a large area of myocardium, multiple vessel disease with a proximal LAD lesion, abnormal LV function related to the native vessels, and a recurrent angina, CHF, and three vessel disease with systolic dysfunction. So, in which cases we can offer redo CABG versus uh, angioplasty is redo CABG is offered if there is a late more than 5 years stenosis, multiple stenotic vein graft, diffusely atherosclerotic vein graft, stenotic LAD graft, no patent internal thoracic artery graft, abnormal LV function. PTCA could be offered if early, less than 5 years stenosis, single stenotic vein graft, other patent vein grafts, and focal graft lesion, and patent lima to LAD graft. Preoperative assessment should be performed with history and physical examination and evaluate the functional status of the patient and look for any comorbidities in the patient, especially like renal disease, pulmonary disease, vascular disease, or any other cardiac problem, including the arrhythmias. We have to look for the conduits which are available for the surgery and routine cardiac investigations like ECG, echo, and cardiac catheterization, viability studies to see how much myocardium is viable and how will the bypass graft affect the patient. Chest CT to see the relationship of the underlying graft in relation to the sternum, and CT pelvis to evaluate for the peripheral vascular disease so that patient can have peripheral cannulation. So if the patient appears to be a candidate for surgical revascularization and not a candidate for PCI, then we can offer uh, it, the surgery. So as we go, take the patient for the surgery, the reduced sternotomy increases the risk of adhesion, and it may be possible that it would be difficult to get access to the heart. So there is application of the defibrillator pads, so that if the patient goes into arrhythmia, we can apply the defibrillator pads and give the shock. Exposure of the femoral artery and the vein, and draping in the way in which femoral artery is exposed, and also right axillary artery is also exposed, and the patient is usually offered single clamp technique. So the cannulation can be performed once the aorta is dissected out and palpate, or use the scan to see the safe cannulation site. One can consider axillary or femoral cannulation, venous cannulation through the right atrium, and then CBP can be initiated. If we need, we can dissect the internal thoracic artery, or right or left, or if it is previously used, then we have to plan accordingly. The myocardial protection should be given by anterograde and retrograde cardioplegia. The challenge arises if the lima is patent. Antegrade cardioplegia alone may protect the area supplied by the patent predicted internal memory artery grafts and may dislodge the debris in the saphenous vein. The retrograde cardioplegia can give the washout to the coronary debris, and it can give access to the occluded arterial graft. So right side cannot be, so it's a challenge to perfuse the right side through the cardioplegia. Clamping the patent arterial graft ensures the uniform cooling. If safe, the lemur can be clamped and in tissues between the left side of the aorta and the medial surface of the left lung. So one has to assess the high-risk situation, RV or aortic enlargement, patent vein graft to RCA, in situ, right intrathoracic artery to LCA, and epicardial thickening scar causes difficulty in identification. One has to determine the vessels and conduit to be bypassed, and we have to replace more than 5 years saphenous vein graft when there is a high degree of atherosclerosis is present. So while operating, one should avoid manipulating the vein grafts, and if there is a stenosis, they can be left in place or divided, and a new grafting can be performed. The proximal anastomosis may be difficult to find, and if there is a previous involvement, so we can do the sequencing vein graft to minimize the number of the proximal anastomosis. The arterial free graft can be anastomosed to the hood of the new or old saphenous vein graft due to lack of atherosclerotic involvement there. So perform Lima to LAD graft if not previously done. Right internal memory artery to the right coronary or PDA can be done. Right radial can be used accordingly according to the indication. So during the bypass, we have to check for the TOE to see the contractility and monitor the patient, and assessment of the Doppler assessment of the grafts can be done. The CABG techniques can use the cardiac stabilizers and with a full cardiopulmonary bypass to revise distal anastomosis. If there is difficulty in getting off bypass, one can use intra-aortic balloon pump or ECMO can be utilized. So reoperation, one has to pay special attention if the LV ejection fraction is less than 35%, and the causes of late mortality include dialysis, stroke, and age more than 65, and the lack of angina, hypercholesterolemia. In summary, CABG is a safe operation. Redo CABG should not be performed in patients having severe MR with poor LV function without the evidence of significant viable myocardium. Thank you.